Good morning on Sunday morning and the last day of the conference. First of all, today I would like to introduce the topics about melasma and hyperpigmentation, which is really, I would not use the word popular, but it's very widespread, very common among the skin of color patient like us. And the incidence is growing maybe due to the UV index, the global warming or whatever. So today we're gonna update the latest technology on treatment this really challenging issue. So firstly, may I introduce myself? So sorry. I'm Nasha Chodhawansak from Chulalongkorn Hospital, Thailand, here in Bangkok, obviously. So firstly, I would like to introduce our first speaker, Professor Shi Luk Kong from Singapore. Today he is about to present the management of patients with cosmetic facial pigmentation disorder. So please give him a big applause.
Good morning, ladies and gentlemen. It's very early. I've got a lot of slides, so I don't think I can finish the slide. I'll just go through because there are so many things to present, and I'll stop when the time is up. So there's a timekeeper, I hope. So I'm going to talk about management of pigmentary disorder, and I think all of you, like what the chairperson has mentioned, is a very common condition. We spend a lot of time treating pigmentary disorders. And there's a difference between the Asian skin and the Caucasian skin. We hate the sun. Unlike the Caucasian, they love the sun. And we have a lot of pigmentation, and the Caucasian had very little pigmentation. They have a lot of telangiectasias and all sorts of changes that you can see. Like what you see here, we see a lot of pigmentary disorder. So if you want to invest in equipment to treat pigment disorder, you will get your money back very quickly. So that's what you can consider. And here, as you can see, the same thing. Pigmentary problem is seen in Asian skin as compared to Caucasian skin. And the other problem of pigment skin, of course, we have a lot of complications that arise from procedural dermatology. So you can get post-inflammatory hyperpigmentation, you can get burn. If you have dark skin, you can get keloid, and then you get a lot of secondary textural changes as a result of the injury because of the damage. And there's a study done by L'Oreal 2-3 years ago on the incidence of pigmentary disorder in 17 countries. And they found that 50% of the population actually suffers from that. Of course, in Asian countries, you have even more in terms of the proportion of people with pigmentary disorder. But if you were to analyze all the pigmentary disorder in the clinic, and this is a study that we did sometime in the National Skin Center, where we examined 600 over consecutive patients who came to see us for pigmentary problem. And then we look, what are the conditions? And it's not very many, There are actually 3 main conditions that you can see. One are the landogens. The other is the Horis nevus or dermatomelaноcytosis. And then melasma is very common. And then the other things like post-inflammatory hyperpigmentation is a secondary condition. So I don't lump them into this part of pigmentary disorder, the primary pigmentary disorder. But if you look at all these things, there are only 3 disorders that you got to make. So just remember, you see a patient, think of these 3 conditions, and then try to confirm the diagnosis. The second thing that you have to do is that you must always remember that your patient, and in fact, most of the time, has got more than one pigmentary disorder. So you can have 1 + 1 or 1 + 2, 1 + 3 and all that. So if you try to treat the patient for one condition, they will never get better. If you look at a melasma patient, you will see quite a high percentage of melasma patient will also have landogens, will also have got Horis nevus sometimes. And if you just focus on one treatment of melasma, patient will never get better. So you cannot tell the patients, yes, I can get your landogens better, but the melasma will continue a topical treatment for a long time, and that's what you need to do. So that's the second thing that you need to do. And here's an example of these 3 conditions that we often see in the Asian patient: landogens, freckles, Horis nevus, and then melasma. So these are the commonest conditions that you see. More than 50% of them will have one of the conditions. And I also mentioned to you about the combination. So you can see that there are 9 charts here, and these charts consist of patients with Horis nevus, landogen primary, melasma, and combinations of various. If you are very unlucky, you'll be number 7, where you have Horis nevus, you have landogens, you have melasma as well, and then you have to decide what you can treat and tell the patient, I have to treat you one condition at a time, and those that cannot be treated with lasers or devices, then topical treatment is the only way to go. So this is the question you ask yourself after you see a patient with pigmentary disorder. So where is the pigment? Is the pigment deep, superficial? Because it decides on what lasers you're going to use, or you're going to use topical treatment alone. And what is the pigment? Some pigment cannot be removed. They are there forever, especially, for example, if you treat tattoos and then you got the green tattoos and the yellow tattoos, you find that it's almost impossible to treat. And the other thing is, what is the biology of the pigmentation? When I talk about biology, I'm talking about the behavior. So if you treat Becker's nevus, all of us have treated Becker's nevus. It's a waste of time. It doesn't work. You always come back with recurrence. So we just tell the patient, cannot be treated at all. Just leave alone. Then they will go and see some other doctor and have the treatment done. So you warn the patient about that. And what is the response to treatment? So again, using Becker's nevus as an example, you treat, they will come back. Cafe au lait macules, it's the same thing. You treat, they will come back. And you'll never get them cured. So you must ask the patient, do you want to have the treatment? You've got to pay for the treatment, and then it's going to recur. And then you decide whether you want to treat or you want to treat, and which can be treated, which cannot be treated. And then you decide on whether you want to use topical treatment or laser treatment or combination of both. And most of the time we use combination treatment nowadays for all these conditions. And this is a simplified chart to show you where the location of the pigmentation is. Usually lesions that are on the epidermis are more easy to treat and they're more amenable to treatment. Those who are in the dermis are usually more difficult, and therefore you have to use long wavelength lasers to treat the deeper dermal pigmentation problem. And then you have a group of conditions where you have a mixture of both derma and epidermis. So you direct your treatment to those, the depth of where the pigment lies, and then some of them can be treated and some of them cannot. And we have this simple schematic diagram to show you that you can actually have many modalities of treatment. The most important of it is the sun avoidance. Avoid the sun, because UV light has got a lot to do with pigmentation and aggravation of pigmentation. And you can peel the skin, you can use block of transfer of melanin, and you can use orotranexamic acid and so on. So there are many treatments, and very often you need combination treatment, or you have to change treatment when the patient doesn't get better, especially when you're treating things like melasma. So here's an example of very simple treat. You identify if the patient is lucky just to have lentigens, solar lentigo, you just use one treatment, 532 or 1064, or 755 nanometer wavelength, and you'll be able to get rid of it very effectively, just one treatment. So you can tell the patient, depending on your diagnosis. So Hori's nevus, you can see, it clears very nicely, but this one needs multiple treatment because it's a dermal melanocytosis. So you can tell the patient, you got Hori's nevus, you got lentigens, both can be treated. We'll have to treat you slowly, one by one. And one of the biggest problems we have in the Asian skin is post-inflammatory hyperpigmentation. So this patient has got lentigens, as you can see. He was treated, and then 1 month later, developed pigmentation. But fortunately, for this kind of post-inflammatory hyperpigmentation, they sort of clear after 3 to 6 months. But some of them can go on for more than a year. So again, you have to look at the risk factor. Are you prone to post-inflammatory hyperpigmentation, and whether you should treat or tell the patient just try topical treatment. But just warn them that you're going to get a PIH, because they will get very upset if they find that they get worse after a month or so, and it takes some time for it to clear. And so with the advent of the Q-switch technology in lasers, as you know, the short pulse duration lasers, you are able to treat a lot of pigmentary disorder. And basically, it works by blasting or breaking up the pigment particles into smaller particles so that the macrophages can come and bring them along slowly. And so in your treatment, you have to gauge according to the level of the pigmentation and how much pigment there are. So some very dark tattoos, like black tattoos, are very difficult to treat, and you need multiple treatment. And these are some of the lasers, all the Q-switch lasers, as you can see. And now we have picosecond lasers as well. And these are later on in the morning. I'll be talking about is it good to get a pigment laser, pico lasers compared to a nanosecond lasers. And basically, as you can see, there are advantages and disadvantages. And we have a lot of PIH in 532 nanometer that we don't even use 532 to treat our pigmentary disorder. Although it's very, very effective, but it causes a lot of PIH. So if you have a Caucasian, you can do that. So these are just some of the examples that you can do. Then we have the picosecond lasers that was introduced about 10, 12 years ago, and it's been a very good laser, but the question is it worth investing in it? You pay double the price of it, and then if you don't have enough patients, it's very expensive. And this has got a very short pulse duration, as you know. It's in the 1 trillionth of a second in terms of its pulse duration, and then you get fragmentation, more photomechanical effect rather than photothermal effect. That's supposed to cause less PIH, but in our experience, we find that it's not the case. You still get the PIH. And this is an example of using a picosecond lasers to treat the Horis nevus. They are very effective. They're just like nanosecond lasers. You get the same result with nanosecond laser, but picosecond lasers, you need less number of treatment, and you get less painful as well. And then you can use a pico or nanosecond to compare even lentigens, and it does work, but you probably need more treatment. Then BIH, we thought that everybody says that picosecond lasers cause less BIH. That's not true, because you can see that this patient, we treat antigens, and then after a month again, they got pigmentation, and then some of them develop erythema, and then 1 month later, the pigmentation started to appear. So warn the patient about the 532 picosecond laser. They are almost identical. Later on, I'll talk about it at 12 o'clock during the other lecture. So you can treat lentigens. And then we come to this big problem that we have with this melasma. There's no diagnosis. It's clinical diagnosis most of the time. And as far as treatment is concerned, there's a pyramid structure that you can do. The most important is sun avoidance, and then we have a lot of topical treatment. And now for most of my patients, the second line treatment is I give them oral tranexamic acid, because topical treatment, laser treatment, is not so effective, and it takes a long time to treat. So you can give them a course 3 to 6 months of tranexamic acid. 70 to 80% of them will clear, will improve. The only problem is that they recur, and therefore you have to give intermittent treatment to control them, and you still need to give them some maintenance treatment with other topical agent. But sunscreen is extremely important. And I show you this study that we did many years ago, where we actually do a lot of trials on melasma and treatment, and then we compare the control. The control are those people who do not receive any active ingredient, just sunscreen alone, nothing else as sunscreen. And we look at the improvement of MASI score in the control group, where the patient receives only sunscreen. And you can see that the MASI score also drops if they use the sunscreen regularly. And here's an example of a patient who just used sunscreen in one of our studies. And so it's very important. The next very important thing is the visible light. In the past, we always thought that visible light is not important. But now studies by Henry Ford Group, Henry Lim, has found that the visible light can cause darkening only in Asian skin, type 3, type 4, 5, 6 skin. So the Caucasian will not have any problem when they are exposed to visible light. But if you expose visible light to Asian skin, type 4, 5, the darker you are, the more likely is your melanocytes get stimulated, and then you get pigmentation. And the pigmentation can last 3 to 6 months. So we believe that the visible light has got something to do with pigmentation and melasma. So now I tell my patients right away, from the sun, cover your face with whatever you have, but you can expose your body if you want to, if you're afraid of vitamin D deficiency. But I think it has got something to do with this darkening of melasma that makes it very difficult to treat. There's no good sunscreen for visible light at the moment, and most people use antioxidant as a form of control for UVA. But this is something which is very important, and I think we must stress that we should not just push aside visible light, because the patient will always ask us, if I shine on a bright spotlight, do I get my melasma? Apparently this study shows that it does. Yes. And again, the treatment of melasma is the same as what I've shown you before. Multimodular kind of treatment gives you better outcome. And tranexamic acid, I mentioned, is a good discovery. We do not know the mechanism of action, but 70 to 80% of patients does very well with treatment. And they get 70 to 80% reduction. They last for 3 to 6 months. They recur, and then you give them a holiday treatment, and then after that you continue and repeat the treatment. We do not know how long it's going to take for the maintenance treatment, but I don't think we are there to give them maintenance treatment, because we don't know what the long-term side effect is going to be like. Now, to end off this melasma and the lasers, is it useful? I never use lasers unless patient force me to do so, and we have tried everything, because most of them will end up with post-inflammatory hyperpigmentation. And there are many studies, especially from Thailand and Korea, that shows that the laser toning, which is very popular to treat melasma, can cause a lot of complications. And they all recur. And therefore, this one last study that was done not so long ago by the Thai colleagues showed that you can get improvement. There's no question about the improvement, but most of them actually recur. They develop mortal hyperpigmentation in 14%, and rebound hyperpigmentations in 18%. So you can see that it's got side effect, and therefore you have to be very careful. And this is the type of things that you see. You see guttate hypomelanosis, and it's very difficult to treat, because you can do anything you do it. The topical cream, you find it doesn't go away, and it's worse than when the patient having the melasma. So don't consider laser toning unless you have really nothing to do and the patient has got no other alternative.
So
Yes. So in conclusion, as you can see, there are many different types of pigmentary disorder, and one should treat it as a total presentation rather than an individual. Thank you very much.
Thank you, Dr. Go. And so you really gave a great overview of the conditions as well as all the possible treatments and a very practical approach from all your experience. Thank you. It's with great pleasure that I now call upon Dr. Anil Ganju, a senior and colleague from India and a dear friend who will share his vast experience with special parameters to treat nevus of Ota. Over to you.
Thank you, chairpersons, Dr. Malvika, for that kind introduction. Thank you, friends. It's nice to see you all here early morning. I was thinking the hall will not have many people here. So I'm going to talk about the nevus of Ota treatment. We've been treating nevus of Ota for a long time with the regular Q-switched lasers, and we've seen that we get wonderful results. But many a time your patients are not really satisfied because 100% results most of the patients do not get. So I've tried to tweak around with the parameters and tried to find out whether we can improve the outcome in patients of nevus of Ota. So lasers have seen a tremendous revolution since the first laser, the Ruby laser came in, and at that time, Ruby was used for almost everything. There was one laser for multiple indications, and now we have multiple lasers for each indication. So we have moved on. Q switching has improved, and we now know that we target the melanosome using an ultra-short pulse width, as Dr. Go just talked about. Tweaking around with the pulse width from the nano. Now we have gone to pico, we have the micro, we have the milli. So we now know how changing the parameters can change the ultimate effect. Nevus of Ota is a dermal melanocytic hamartoma that is present since childhood, and usually it presents as a bluish to slate gray hyperpigmentation along the first and the second branch of the trigeminal nerve. And the pigmentation progressively increases, and particularly around puberty, it shows an increase. And Q-switched lasers have successfully treated most of the patients of nevus of Ota, and they have really changed the approach in managing this difficult condition, and most of the patients do well. However, there are a set of patients who will not have full results and will not be very satisfied. So we did a large study on our patients of pigmented lesions using the Q-switched laser, and out of them about 44 were nevus of Ota, who showed fairly good response. About 31 out of them showed a 50 to 75% clearance, but a good 13 did not show a very good clearance if we consider less than 50. So I'm presenting a case of nevus of Ota, where we changed the parameters and added a procedure to get a better outcome. So this was a 25-year-old female who presented with the typical macular pigmentation of nevus of Ota in the infraorbital area on the right side, and this had been present since birth. It had slightly increased at puberty, the usual history. The lesions were asymptomatic, and the major concern was cosmetic. So she was started on the regular Q-switched laser sessions done every 6 weeks. The conventional parameters of a 6 mm spot, 4.2 joules of energy per square centimeter, and a frequency of 5 to 10 hertz was used at each sitting. And after 8 sittings, we found that there was good response, but the patient was not happy. You see, there is some pigmentation still there, and the patient was not improving further. So at this time, we decided to add 2 techniques to our procedure. We did multiple passes using different spot sizes, and we added a pass of carbon dioxide fractional laser. Now, the spot size has a bearing on the depth of penetration. The larger the spot, the deeper you go. The smaller the spot, the more superficial you go. So there's a concept that has been developed over the recent past that if you do multiple passes of Q-switched laser using different spot sizes, you will penetrate at different levels and therefore clear the pigment better. The pigment lying at different levels will be cleared better. There was this chapter in our national book that our association publishes where one of my friends had worked on this technique, and he said that using the multiple spot sizes of 6, 9, and 4, using similar energy, could clear dyschromia better because of the reason that I just told you. But in our skins of color, the darker skins, it's preferable not to use higher energies and not to produce the typical frosting that we look at that has been said earlier as an endpoint. We just produce a little bit of erythema. A mild frost is okay, no petechiae at all, because that can produce post-inflammatory hyperpigmentation. So this is a diagrammatic representation of what what I've already told you, the multiple spot sizes, penetrating to different depths and therefore clearing pigment at different levels. Now, the idea of adding the fractional CO2 pass was for better clearance because okay, so fractional lasers basically are used for resurfacing, but then we know that it creates these micro channels of coagulation within the dermis, and there is a channel that is created. And it has been seen in studies that various dermal materials are extruded through these channels, and this is known as the transepidermal elimination of material from the dermis. So there are a number of conditions like amyloidosis, like tattoos, like even pigmentation, etc., of the nevus of aorta, where they have seen that this dermal material, including melanin, can get extruded through these channels that have been created by the fractional laser. So we used this thing and did a pass of fractional laser following the multiple spot sizes in our patients. So it has been proven in a number of studies, and there are a number of papers which say that this transepidermal elimination of the dermal matters happens when you are creating these microchannels within the skin. And you can see that 2 sessions following those 8 sessions of conventional. So 8 sessions conventional, I had shown you the results. 2 sessions addition of these multiple spot size passes of Q-switch and a pass of carbon dioxide fractional almost completely cleared the lesion. So the patient was very happy. So nevus of aorta responds well to our conventional lasers, but some patients want more clearance, and you would want to give them more clearance, and using multiple passes with different spot sizes can help you remove the pigment at different levels and add a fractional CO2 pass, which will help you eliminate the pigment from the dermis better. So it's just like learning from your experiences. I do a little bit of bird photography. The bird at the top is one that I shot in India way back in October 15, and I thought I have got the best night heron. And then in Singapore, Dr. Go, I shot this one with the catch, and I knew that you can always do better. So there's always a scope to learn. And this is 2018, and I have now further evolved, and I do better photography now. So learn more things, add more things to your practice. You're going to give better to your patients. Thank you very much.
Thank you very much, Dr. Kanju. The result is very impressive, and thank you for add more technique to deal with the nevus of aorta, which is very challenging. Then we will introduce to my dear colleagues from Thailand, Dr. Yada Ittipanichpong. So she is a dermatologist in Bangkok, and she will share about the optimizing procedure approach for melasma across all skin types, which her best approach. Please give a big applause to Dr. Yada.
Good morning, everyone. Thank you for being here in such an early morning session. So first of all, my name is Yara Ittipanichpong, and currently I'm now as an adjunct faculty member in Chulalongkorn University, and I work in the private hospital, and I have my own private practice too. So the topic that I'm going to talk today is about melasma, which is the topic that I like the most. And it's going to be about treating melasma by the procedures across all skin type. This is my disclosures. So the challenge of treating melasma is that because of the skin type itself and also the environment, because the environment will have an effect on what your patient going to be exposed to after the treatment as well. So even if something is like very suitable for them, but the environment or their lifestyle cannot suit it, it might not be the good treatment for them. So we have to take into account for all of this. So let's go briefly about the pathogenesis of melasma. We already know that it just go beyond melanocyte itself. So it's also about mast cells and solar elastosis, dermal aging, weak basement membrane, and neovascularizations. So when we treat melasma, it's not only about pigment anymore. So we have to think around and everything because there are other stuff too. Okay, so that's why I categorize the treatment approaches into 3 phases here. The first one will be the priming, the pre-procedural priming, which is very important. And the second, addressing vascular and dermal component. And the third one, to address the pigment component. But actually, the fourth one would be the maintenance phase. But I know you guys already know it, and in a very short time, I'm not going to talk about it. So only the procedurals here. First, the phase 1. It's very important. I will say that this one is a non-negotiable step. So we take this time around like 2 to 4 weeks prior to any procedures because it will help suppress tyrosinase activities and stabilize melanocyte before any physical trauma or before any treatment that we're going to do afterward. It can be either topical agent or the systemic agent. So these are all the topical medication that has the evidence supporting using it to treat melasma here. And And this is the oral treatment. The oral treatment, all these have the evidence supporting using it too. One of the treatment that I like the most is the oral tranexamic acid here. These are some of the literatures and studies that have the evidence to show the recommendation for the dosage for melasma. So right now it's 500 milligram per day, and because in this dosage there is no report of the side effect, and also the relapse rate is lower compared to the higher dose one. So right now we tend to use like 500 milligram per day. But in Thailand we have like the capsule that is like 250, but in the US they have like 375, right? So in Thailand we use 250 twice a day. And phase 2, the vascular and dermal phase. For the vascular, you can use either pulse dye laser, which is one of the treatment and one of the laser that I like the most, and the injectables here. But when you do the vascular treatment, always use the low fluence and the subpulparic threshold. The endpoint would be very, very mild erythema, not the purpural one. Next, to do the dermal component. To address the dermal component, this is in order to repair the weak basement membrane that I mentioned in the pathogenesis here. The procedures can be microneedling, or the microneedling RF and PRP, which have the strong evidence supporting. Next, we're going to move on to the pigment phase. For the pigment phase, we can use either the chemical peels or the laser and light therapy. So the trend right now for the chemical peel, and it's safe for all of the skin type, is that we are moving away from the aggressive peel to the shallow, repetitive treatment and peel. For laser, it's kind of like we have to beware because if you use too high fluence, it can cause a relapse of melasma. So always use low fluence for melasma, and it's safe for the higher skin type, especially like skin type 4 and 5 too. Or you can use the injectables such as the tranexamic acid, vitamin C, and platelet-rich plasma. So these are all the treatment options here. The photoprotection, this is of course the most important one. But I'm going to focus more on the injectable, which I like the most because it's like very safe and very low rate of the having relapse of rebound melasma. And it's safe for like our climate as well. So for the injectable of melasma here, there are like 6 agents that have 6 medication that have the evidence supporting using it. But for me, I will talk about number 1, 2, and 3, PRP, tranexamic acid, and vitamin C. First of all, you already know that PRP, it helps with the wound healing and collagen formation and help repair the weak basement membrane too. These are the studies that support using it. And PRP here, the preparation would be like this. The combination, there are a lot of studies suggesting doing the combination with other modalities, especially in microneedling with PRP. Next is tranexamic acid. Tranexamic acid here, I have been prescribed my patient with the oral tranexamic acid and injectable, the intralesional tranexamic acid for more than 10 years, and I think I love tranexamic acid. So it acts on melasma in 3 pathways: antiplasmin, anti-angiogenic, and inhibitory effect on mast cell. So you can take a look at the studies here. There is a pathology, and you can see there is an improvement in all of these 3 aspects after injecting and oral melasma, oral tranexamic acid. So these are all the review of the literatures from the dosage and the protocol that we use the tranexamic acid. So the dosage can be ranged from 4 to 100 milligram per ml. The injection technique, they use the intradermal, 1 centimeter apart, around like 0.05 ml each. The interval can be weekly, bi-weekly, or monthly, and the improvement usually seen after 4 weeks after the treatment. There is combination. You can use it with other modalities as well. So, but however, there is no control study on tranexamic acid. So that's why we conduct a study with Ajahn Chanat here. And we did a split-phase control study comparing between tranexamic acid and normal saline. So, and in the tranexamic acid side, we divide into the low dose one, the 4 milligram per ml, and the high dose one, which is the 40 milligram per ml. And we injected it 5 sessions every 2 weeks, and then we follow up the patient until 2 months post the last treatment. And the result in MASI score, you can see that there is a significant reduction in the MASI score in the tranexamic acid, which is the blue line here, the light blue and the dark blue here. The red one is normal saline. There is a significant reduction of the MASI score from the tranexamic acid injection site. But what is interesting is that the blue one, which is the low dose one, performed better. And you can see that the low dose one reached the significant at actually week 4, but I missed the star over there. At week 4, which is earlier compared to the high dose one, which is very interesting because I think everything is like dose dependent. So this is a patient here. You can see the tranexamic acid site, melasma is better, and the patient can observe it. And this is another one of my patients who has been injected with tranexamic acid. And, let me see. Okay, so is it dose related? Because the lower dose one performed better. So, and it's also like in accordance with other previous study as well. So our hypothesis is that maybe the receptor is like there is a receptor saturation in the higher tranexamic acid dose because the low dose one performed better. So this is just our observation and our hypothesis, but we have to carry on another study to prove it too. Next, the vitamin C. We already know that vitamin C is a potent antioxidant and it inhibits melanogenesis because it's bind with copper, right? And this is all of their studies that supporting using vitamin C for treating melasma here. Some of them, they did a combination with tranexamic acid as well. So what I like the most is their platelet-rich plasma, PRP, tranexamic acid, and vitamin C. So when I do it, before that, I use the tranexamic acid alone, but later on, I add with PRP, and all of my patients love the result. So I inject tranexamic acid with vitamin C in a grid patterns, 1 centimeter apart, and between each dot, I inject the PRP intradermally as well. But there would be some of the PRP left, and I do like micro needles with the PRP. And there is a PPP left. I use it like topically around the phase 2. So it's kind of like, but it's like optional. The last one is like optional. It depends on the patient. If they don't want that much of the downtime, we can stick to this. The first 2 is okay. So this is how I inject it, like manually. It's like intradermal, 1 centimeter apart. We stretch the skin. You can see a branching after you inject the agent in. Yeah. And after that, I will do with the mesotherapy, or sometimes I use with the injector gun too. This is a picture of my patients here. You can see the improvement in melasma. This is before and after on the different sites. This is 5 sessions of tranexamic acid and vitamin C and platelet-rich plasma here. And this is another one, 5 sessions of tranexamic acid and vitamin C and PRP. And my patient loved the result. And you can see there, in terms of like their skin rejuvenation, he also loved it too. Conclusion. So we already know that melasma is not only about the pigment, so we have to address other stuff too, such as the vascularization, weak basement membrane, and all of like dermal aging. So, and the last but not least, steady care wins over the quick fixes. That's what I tell my patient every time. And it's chronic, no cure for that. The improvement rate is like, there is another literature, they gather like all of their experts who treat melasma around the world. And they say it's like, how many % you see, is it like the successful improvement from melasma? What do you think? There's just like 70. Like 10 consensus from like dermatology. And I didn't put it here, but there's like 70% is like considered to be successful treatment for melasma. Of course, I think like all of you, so like sometimes we see like 90 sometimes. Yeah, but this is what I tell my patient. It's like, you know, the expert, dermatologists like all over the world, 70. Okay, I see some 90. But no, there is no 100. That's what I tell my patient every time. And melasma comes, and doctors say that it come and go. It's like a ghost. Sometimes it's better, but when you increase, like we go aggressive a little bit more, boom, it's come back. So we have to be gentle with melasma, just like I be gentle with my kids. So I be gentle with my kid, and I will be gentle with melasma too. Thank you very much.
Thank you. Yeah. Yeah. That is a great analogy and a very nice presentation of your experience and unusual and interesting data as well. Thank you. With great pleasure, I invite Dr. Patrick Huang, who will speak on melasma revisited beyond photoaging, pigment selective lasers, and practice protocols. With his wide experience, I'm sure Dr. Patrick Huang is going to show us his cases and work.
Good morning, everyone. Dr. Patrick Huang, dermatologist from Kaohsiung, Taiwan. So really a pleasure and honor to be here to share how I manage a melasma patient with pigment selective lasers and the practical protocol. So, you know, after the previous lecture, we already know there's no perfect way to manage melasma. So, but, you know, so I think there's a question. So over the years, we have seen pigment laser toning, fractional laser, and more recently, microneedling RF promoting as an effective management. Yet in daily practice, the result often less impressive than what we hear on the podium. So this raises an important question. So are we following the evidence or are we following the excitement? So today, I would like to review the evidence, actually tell us about the laser and energy-based devices in melasma. So here's my disclosure of the past year. So is melasma a photoaging skin disorder or simply a pigmented condition? So when I was a resident, this was 30 years ago, so we used to classify melasma as epidermal, dermal, or mixed type. So today we know that reality is much more complex, and the most melasma contains both epidermal and the dermal component, with melanophage distributed at different depths of the skin. So however, one of the most important discovery in the recent years has been recognized basement membrane disruptor in melasma. So these findings are fundamentally changed the way many dermatologists approach melasma. So shifting our focus from pigmentation alone to the underlying structural change within the skin. So today we know that melasma is much more than a pigmentary disorder. So increasing evidence suggests that photoaging, chronic inflammation, vascular change, and the skin barrier disruption all played important role in its pathogenesis. So as we have already heard from the previous speakers, melasma is a complex multifactorial disease, and our treatment strategy need to reflect the complexity. So once our understanding of melasma change, our treatment strategy must change as well. So it is not longer just about removing pigment or comprehensive approach is often needed. However, for today's discussion, I will mainly focus on specifically on pigment selective laser and where they still fit in modern melasma management. So before using laser, I always start from topical and systemic like the previous speakers. However, I no longer use hydroquinone routinely for melasma. It is effective, sometimes too effective, and result in uneven pigmentation. So we also need to keep the risk of the exogenous ochronosis in mind. So for long-term management, I often favor safer option. But because I'm really like a chicken in my practice. So such as azelaic acid. And the result may be not really dramatic, but the safety profile is much more important. So according to the consensus from the SAISHA, which is the organization I work with Professor Go online, and we had a consensus discussion 4 years ago, and we highly recommend prescribing oral tranexamic acid 500 milligram per day as a first-line treatment before laser. So usually patients responded quite well, and you may think that tapering after 3 months of the use, and because melasma may come back soon in some patients, so you may taper down to 250 per day. So before we talk about pigment selective laser, I would like to share a story about RF microneedling for melasma. So this study not really about RF. It's about how we interpreted evidence and the difference between statistical significance and the meaningful clinical benefit. So several years ago, I met the author of this paper when she was invited to lecture in Taiwan. She's a professor in South Korea. What impressed me most was not the technology itself, but the honesty behind the study. The author compared 1064 nanosecond laser toning along with laser toning combined with RF microneedling for melasma. At the first glance, this seems like a typical comparison of laser toning alone versus laser toning combined with RF microneedling. But in the paper highlights an important lesson. Statistically, significance does not always mean clinical significance. So I often use the example of two classes of students. One average is 62, the other 65. With enough student, the difference may be statistically significant. But as a clinician, would I consider those outcomes meaningful, different? Probably not. So as that's the trap we often encounter when reading clinical study. A significant p-value does not necessarily mean a meaningful benefit for our patient. So this is an interesting study that the author found that when using laser toning, about 4 out of 15 or just under 30 saw moderate to significant improvement. So when using combination therapy, about 7 out of 15 or just under 50 got moderate to significant improvement. So now it's a time to talk about laser. So the concept of multiple passes of low fluence Q-switch laser was developed by Dr. David Goldberg. And based on the theory of subcellular selective photosynthesis, we would advise our colleagues to use low fluence. So however, after laser toning, more dendritic cells in the lesional skin were observed at the level of dermal-epidermal junction, although melanin index value was decreased. So although the skin looks lighter, the melanocytes stay very active, and in some area, they became even more active. So this shows the wild pigment can be reduced. The cell that make pigment may still stimulated, and which can lead to melasma coming back. So in this article published before and following an 8-week treatment period, 532 picosecond and 1064 picosecond decreased the length and the width of dendritic melanocyte in the lesional skin, while melanin density and the intensity remain relatively unchanged. So I guess this publication reached support that what we observed the daily practice and what some publication did not emphasize. This very early study showed that efficacy of PCOS toning is not just so, the result is just so-so. So only 30% of the patient improved moderately. To me, not very good improvement is meaningful, and only very good improvement is very meaningful. So the MESI only went from 9 to 6.5, which means the improvement is not a surprise to the patient, including the doctor. So this is another one to compare 1064 and 755. But you know, in the end, for a good responder to picosecond laser, even though skin lesion improve, increased inflammation will eventually produce more melanin from active melanocyte. So today we recognize that pico and the nanosecond laser can sometimes lead to hyperpigmentation, induce the rosacea-like reaction, a rebound hyperpigmentation. So so we need to think about how we use laser nowadays. So personally, I don't like using laser for melasma. So although that today I'm going to talk about melasma management, but I also cannot ignore the clinical reality. So the key is not whether we use laser, but how we select patient, how we treat, and how we set expectation. So before using laser, we also have to recognize that the stabilization of melanocyte and removing melanin within keratinocyte are equally important. So that's why that using oral medication is so important before starting laser. So if the patient with good response to oral medication, are we trying to using laser again? So probably not. So however, in this publication about fractional UV laser in treating melasma, this, my friend, Belgian Kim from Chowan University in South Korea, found that after receiving 6 sessions of professional ruby laser at 2 weeks interval, the MESI score showing improvement from 15 down to 10. So so before the laser toning accepted, actually ruby laser is as a traditional way to treat melasma. But actually, in that publication, we know that once we use ruby laser to remove pigmentation, actually pigmentation or hyperpigmentation will coming back very, very soon. So eventually, because of the publication that by my friend, I eventually use fractional ruby laser to remove to improve my patient, because the patient under oral medication, or they don't want to have medication. We still need to do something, for example, topical, but if the pigmentation is still there, we may think about some way to remove pigment, but safely. So that's why I choose this, because ruby laser can remove pigment efficiently, and also you can see the distribution of the energy is so even. So, this is the study I did before. We try to analyze or mapping the pigmentation. So this is a before and after under polarized light after one treatment. So you can take a look at this from skin. That's the type 5 skin color area decreased from 23% to 9%, which means that the darkest spot we categorize as type 5 skin color, and for the darkest part actually decreased significantly. And this one, the darkest spot actually decreased from 19 to 7%. So that's why that we're thinking about that how to use this efficiently. So let me show you this one where I submit this publication, this manuscript to the journal. So take a look at the area that's a type 3 skin color increase at the after first 2 treatment session. And this is a type 3 and a 4. So they get more and more up to 90% after 4 times of treatment. So this is the darkest area getting smaller. So this is a study we did before, so you can take a look here. And So after treatment, lighter skin color area become more, and the darker skin type area for dermatologic type 5 decrease gradually. So more importantly, this is a very safe way. There's no case showing downtime, and once the patient need to have more efficient treatment, you can start to use topical. So you can remove part of the darker area safely, but you can also combine with oral and the topical together. Then make sure that the pigment won't coming back easily. So this is the before and after, and because of time limit, I will go to the conclusion here. So from this preliminary observation, we found multiple fractional ruby laser toning might be a safer and effective strategy to manage patients with melasma. No downtime, side effect, even in no case of laser toning induce of hyperpigmentation sensitivity, because when we treat fractional ruby laser, there will be no overlap. So which is so important. So this would can lower the risk of hyperpigmentation or hypopigmentation and even rosacea-like sensitive skin. So it's been part of my practice. So thank you so much for your attention. Thank you.
Thank you, Dr. Huang, so much for sharing the technique and insight thought. Then we will move to our next speaker, Dr. Laiba Sheikh, direct from UAE. So please give her a big plot. And today she will tell us about comparative efficacy and safety of topical tranexamic acids versus the hydroquinone in treatment of facial melasma and RCT. Yeah, please give her a big applause. Thank you.
Thank you, guys. Good morning. My name is Dr. Laiba Ali, and I am a dermatologist and aesthetic physician. I'm practicing currently in Dubai, and I'm going to be presenting a randomized control trial comparing topical tranexamic acid versus hydroquinone for facial melasma. As my colleagues have mentioned already, that melasma, they've briefed a lot about it. I don't think I need to go again, but still, melasma is actually a very frustrating pigmenting disorder that we have been seeing in our clinical practices every day. To find the correct treatment that is actually having a good tolerability is always challenging for us. Melasma is seen in adults, but mostly I see this in my clinical practice. I've seen women usually going through melasma, and women with usually with childbearing age, and also with a darker skin type. So melasma does not only affect when it comes on the physical appearance, but it is also affecting people with their self-esteem, and it is also affecting a lot of their lifestyle, how they're working out in their lifestyles. So the reason I am having this study is that we know that melasma usually is the gold standard treatment we have for melasma is hydroquinone, generally in our practices. But because of the limitations we have, that when we have been using hydroquinone in the long term, we see there's irritation, we see allergic dermatitis, and also in severe cases, we see that, like my colleague mentioned, that we see uneven skin tone happening because of overperforming of the drug. Hence, we did a study where we made two groups of 120 people in total. We divided both the groups, and we gave them hydroquinone 4% and tranexamic acid topically 5% to be used twice daily for 8 weeks. So the objective of our study was to compare the efficacy and safety of the topical tranexamic acid versus the hydroquinone in facial melasma. According to our study, our hypothesis is that the topical tranexamic acid provides non-inferior mass reduction with better tolerability than hydroquinone. We're short on time, that's why I tried to reduce the slides, but we're already running late. So I will just quickly go through. We have time? Okay, that's fine, all right. So like I mentioned, the method was done that we divided both the patients, the groupings, and when the eligibility was done, both the patients' criteria it wasn't very different. Like the age, the dermal, the melasma, epidermal, dermal, it was mixed together. Also, the duration of how long the melasma was there wasn't very different. So the gender, the age, the type of the melasma, and for how long the duration, there wasn't much of a difference. So statically, if we see, the study was conducted in a good manner, and the comparison was easily done. Alongside with the topical use, we insisted and made it mandatory for all the applicants to be using SPF along with moisturizer as a compulsion to see how the outcomes would be. And like my colleague mentioned, that only seeing SPF being used consistently gave a lot of difference in the results of melasma, like I mentioned here. So now if we see in the results, by the week 4, we had already seen a lot of results coming up with just the use of tranexamic acid and hydroquinone, but both the results were significant. There wasn't a major difference when it came out to the outcomes. So the result for tranexamic acid was 33.2%, whereas for hydroquinone was 31%. Now when we see the results are similar, but the adverse effects that come up with hydroquinone were far more. These were the before and afters. If we see week 1, that was that condition of the patient, and then week 4, there is significant results just with proper use of sunblock and tranexamic acid. This is done in the week 4 and week 1 with hydroquinone, but you see there is mild irritation seen around this area of the skin, which means there was significant allergic dermatitis seen. Here are the adverse effects. If we see erythema, irritation, and dryness, it is half more for hydroquinone compared to tranexamic acid. Hence, there was better satisfaction seen in terms of the patient outcome when people were using tranexamic acid and compared to hydroquinone. So the mass reduction with tranexamic acid was statically similar to hydroquinone, like I mentioned, 33% to 31%. Half the improvement was already evident by week 4, even though we did the trial for 8 weeks, but we could see good results by week 4. And tranexamic acid showed a markedly better safety profile, roughly half the erythema irritation, like I mentioned, with hydroquinone. And the reason we see that tranexamic acid is working better is because of its way it targets the pathways when it comes to melasma. Also, it is anti-inflammatory, anti-angiogenic, which is also working in the vascular component of melasma, plus inhibiting the plasminogen activation, which also reduces the melanocyte stimulation, again, reducing the pigmentation. So comparatively, again, like we mentioned, we do combine it with different treatments, but here the study was only whole done with topicals. So the limitations with this study was that it was only done for 8 weeks, so I don't have further follow-up of what was going on after, if it reoccurred or something like that happened with the patient. So study has some limitations. Also, the study was done in a single country population, so this was just done in an Asian skin type, done in a clinic in Pakistan. So it was, I don't know if we go in a different area, what would be the outcome. So this is done specifically in Pakistan. So my conclusion is that tranexamic acid topically matched the results nearby to hydroquinone, superior safety and satisfaction, and the adverse effects were half. Significantly, patients were more happy. And again, I would prefer that clinical implications would be better if we use tranexamic acid, and it was well tolerated in the clinical practice. But again, I would say that we should have more studies done towards there because there is not much evident between the comparison of both the drugs and how they're working on the skins. So I would request and prefer more studies to be out there. Thank you. Thank you for paying attention. Any questions? I'm here.
Thank you so much, Dr. Ali, for very interesting newest RCT that show us today. So next we will move to the next session, which is Q&A. So if any participant have any questions, please come to the microphone, and we have all the speakers stand by here. Meanwhile, we waiting for the questions. May I ask Dr. Ali, since your study is very interesting, what is the preparation for the tranexamic? How many percent and how often do you use it? And any specific concern to think about?
So we always were maintaining the skin barrier with a proper use of moisturizer, and hyaluronic acid were preferred. 5% of tranexamic acid and 4% of hydroquinone, but in the practice, I prefer 5% twice daily, at least for 8 weeks to see the results.
So you apply all over the
No,
skin
not all
or
over the
just
face,
on
just the pigmented areas we prefer, because that would always give in the difference.
Was that priming? Were you priming the skin and then continued this in between also
Yes, yes,
for the course of the study?
yes, yes.
What's your personal experience with tranexamic acid?
I would say that the tolerance was far better And I was more relaxed when I had given them the tranexamic acid and compared to the hydroquinone, because hydroquinone can go wrong in a lot of situations. So I did see a lot of improvement in the results, and I had showed few pictures as well. There was significant results when it came to consistent use, though.
Okay. Thank you so much. Then I would have some question for Dr. Huang. Okay, since you say, I mean, in this era, all of the patient and the physician as well really love to do the laser on the melasma and other hyperpigmented disorder. So if it comes, what kind of the case that you will decide to start the laser treatment?
Okay, melasma patient usually not only has melasma, sometimes they also have lentigens. So this is the best part that we can solve first. Lentigen and melasma, they are all pigmented condition. So once you can remove some of them, the patient will be very happy. So this is the first one. The second one is when the patient used topical, I always suggest tranexamic as oral first, and you still see some pigmentation left. So that's a good opportunity that we can manage with laser. So, I tried some other laser or even IPL before, but actually it's very hard to improve melasma with IPL. Sometimes it brings more reaction again and repigmentation. So that's why I try to take the pigment like a fractional way, remove it, part of it. So it will be much safer, because when we do laser toning, actually we do it repeatedly and at the same section. And so that's the reason why we probably will make the melanocyte angry. So that's why I try to do that. So nowadays, I really suggest my patient put the laser as a top priority for the management. That's not really, this is an honest way, but it's very stupid, because it's like push your patient away from your office. But that patient will have a very good relationship with you, especially they will trust all the suggestions you will have for them. So this is a part of the patient-doctor relationship enhancement.
Okay, thank you so much.
Dr. Huang, the Ruby laser was around in the late 90s.
What is that?
The Ruby laser
Yes.
came around the late 90s. And that time the risk of PIH was very, very high.
Right.
So are you saying that now the Ruby, even
okay.
alone, has evolved to that degree and the risk of PIH is not a reality?
Okay, and so the old style of the Ruby laser is 100% coverage. So now we are using only about 40%. And the 40%, because when we use it, it still keep moving. So usually it's a coverage of about 20 to 40%. Yeah, so it's a reasonable way that will take some of the pigment away from the skin separately. Actually, every single spot, actually, they are not very, very close. So we can take part of them. So you can do it at once. And so next time, patient will say, oh, it starts to look better. So you can do another time. So it's not just only like using topical, because of some pigmentation is still there. So I try to remove it in a safer way. So I don't have any case showing rebound pigmentation or rosacea. It's just so very, very common to make the repeated laser treatment will make skin very, very sensitive. So I have no patient with the sensitivity and also pigmentation. So it's just totally different from the traditional way.
That's good to know. And do you space it out longer, at 6 to 8 weeks, or do you still?
Usually 4 weeks, 6 weeks. Okay, it's okay, because I really see patient pigmentation coming back during treatment. So which means that the spacing is probably not really important. Yeah. So it's because we keep the melanocyte quite stable.
Thank you for the explanation. Dr. Go, you mentioned that melasma and Hori's macules often go together. So
They may go together.
They often go together. So would you say that in such a case you would avoid laser, or would you, because they respond differently to laser, the melasma and the Hori's, and the patient may not be happy thinking that they're still not better. So
Yeah.
do you avoid or do you do the laser and then selective settings for laser for melasma and laser for horis?
I try to separate where I can. If the horis nevus is very obvious, then I may do a very targeted lesion on the individual spots. But you must remember that when you treat horis nevus, the first few treatments, they will get worse, because the pigment get broken up and then it becomes very diffuse. So you may look as though the melasma gets worse. So you must reassure the patient you need multiple treatment. But sometimes I do if it's very discrete. If the horis nevus lesion is very discrete that you can see them in small round spots, then you can treat the individual spot. But for melasma, usually we encourage topical treatment.
Thank you. Do you think the dermoscope is of any value? The dermoscope in between sessions. Of course, a skin analysis system will always help, but do you think a simple dermoscope, doctor? Do you think a simple how do you evaluate, how do you tell your patients you're better? Sometimes they're not as good as what the treatment is
use the
effective, but they don't
dermoscope
see it
too.
clinically.
I use the dermoscope too because sometimes it's like when you point out the thing is that there is like we call like the new term is like telangiectatic melasma, and that's one we can see from the dermoscope. And I can point to the patient. You see like the outer telangiectacy here, especially on the melasma area, and then where there is like normal skin, there is less telangiectasia. And in that case, I would prefer to do the pulse dye laser first before doing any procedures. And when I perform other procedure after the pulse dye laser, there is less inflammation and the improvement like is better because like after they put on any like topical treatment or any procedure, it's not as red as it used to be because I treat the vascular component first. So I use the dermoscope too. Do you use it too?
Yes, absolutely.
Yeah.
I use it
love
before I start treatment, during treatments, and it helps to connect with the patient. As you said, Dr. Patrick, we have to connect with the patient of melasma to keep them with us and see how it behaves and walk them through it and reassure them, of course, and keep changing the modality. Yes, Dr. Anil, I was just coming to you.
I was going to ask something. Okay, Dr. Go brought in this, diffusion of pigment after some sessions in some patients. Some of my patients, particularly the LPP patients where I am doing, sometimes the pigment is a little discrete and 2 or 3 sessions it becomes although a little subtle, but becomes diffuse and the patient thinks that it has worsened. And we also, many a time think that the area has become larger. So Dr. Go, Dr. Patrick, have you seen this? How do you address this? Is there something that we can do to, prevent that diffusion of pigment? It goes, if it is over a small area, speckled, I treat LPP, and 2 or 3 sessions it becomes diffuse, although lighter, but it goes over a larger area. I've seen that happening.
Well, yes. Sometimes I do a smaller treated area just within the part of the lesion, so they can make the surrounding skin less reaction to the laser. Because we are darker skin type, so when we hit the horis nevus, actually, usually the reaction to the laser will be strong enough to become pigmented. So that's why I try to just only, for example, central part of the 80%. Then we can avoid the pigmentation in the surrounding area. Yeah, and also treating horis nevus actually. What I'm doing actually, I use 694, which is a ruby laser, and we usually treat about 3 to 4 times. And I would tell the patient the clearance rate is about 80 to 90%. And then if they would like to have the 100% clearance, then they can coming back for 1 or 2 more treatment sessions. So that's what I explain in advance. So the patient fully can understand the situation that they will face.
Also, Dr. Patrick, as Dr. Malvika was mentioning, we have been very skeptical about using ruby,
Right,
we have been told that no ruby for our kinds of skins. And now you tell me that ruby is giving you better results. Do you think you've been working on nano, you've been working on pico, and now
no.
the ruby?
No, the ruby only have nanosecond.
So you've been working with Andy-Ag, and coming from Andy-Ag to pico. Do you feel that the results have improved?
Well, yes, because I used to use, no, actually I have Pico 1064, and we know the reaction of the melanin to 1064 is lower than 694.
Yeah.
So this is the reason why I always choose 694, and also did comparison among 694, 755, and 1064. Actually, the reaction to 755 and 694 are similar, but 1064 is far less effective. So that's why I always use the 694. And I didn't have any experience of using Pico 1064 because although I also have that kind of equipment, but I didn't use it. And probably the response will be better than Nano, but I'm not so sure.
So are your fluences much less than the NDAG?
Much no. The treatment response, in some cases, not all cases, some cases probably response less to 1064.
No, I wanted to know, are you skeptical using, Ruby? Because it will be absorbed into the melanin. It has a short wavelength.
Yes.
We were not supposed to use it, We have never used it. So
Yeah.
are you careful using lesser fluences than your NDAG, 1064-532?
No. Actually, I'm not sure if I get the point, but I rarely use Pico 1064 for a pigmentary condition because of my currently I mainly use 694. So I try to make my patient happy with less treatment session. So that's
Okay,
why.
thank you.
Yeah, talking about the diffuse pigmentation, it's not uncommon. I see quite a lot of them. In fact, I warn my patient about this diffuse pigmentation that makes them look worse. But you persist with the treatment. You tell the patient to persist with the treatment, and over a period of time, you think they will improve to the point of some of them even clear up more than 90%, up to 100%. So, and then on top of that, we tell them to use sunscreen and use topical treatment at the same time, and then they need usually 7 to 8 treatment. But with the picosecond laser, you can actually reduce the number of treatment to achieve the end result. Now, talking about ruby lasers, if you look around, I think there are very few people who use ruby laser. Our experience with ruby laser when it was first introduced was it caused a lot of hypopigmentation, not BIH. I mean, they all get BIH, but they get hypopigmentation. And the hypopigmentation is very difficult, and this is usually seen in colored people with skin of color. So for our Asian population, we have 3, 4, 5. So those 4, 5 people cannot use ruby laser. They will get burned, and then they'll get hypopigmentation. And that's the reason why it sort of went out of favor, and we don't see them. Now they are bringing it back again, and I have no experience with that at all.
Well, this is about the fluence. It's everything about fluence. So usually I use barely seeing the frosting. So that's why it's good enough. I know some patient told me, no, my mentor in Taiwan told me, why not remove it at once? Because you deliver at high fluence, actually that probably the treatment effect will be more even. But I'm also quite worried about the hypopigmentation. So very low fluence, actually you can barely see the frosting is good enough. So that's the way I treat. That was my point.
Yeah.
Right. This is
Yeah, the energy is low. It's fractionated and low. Dr. Ganju, in your case, wonderful results by adding the fractional CO2. Again, were your settings low, and did you do it right after the Q switched? Okay.
No. My settings for Kiva support are usually aggressive, although I don't produce Pitiki, which we used to produce at one time when we started our practice. That was our endpoint at that time. But my, for Nivasofota particularly, the settings are aggressive, which means about 4 to 6 joules at a 6 mm. And as I told you, I work at 8 mm, 6 mm, 4 mm. I give all the 3 passes.
So then what's the energy at 8, 6,
I would
and
give
4?
similar energy at all the spots.
Even at 4 mm?
Even at 4 mm. Because if you increase the energy, there's always a chance of, producing collateral damage and post-inflammatory pigmentation.
But at 4 mm, you don't get purpuric reaction.
No, we don't get purpuric reaction. Yeah, we may get a little bit, but generally I avoid getting purpura.
So subpurpuric.
Yeah,
And then you do the CO2
I do the
on the same day.
same place.
Same. And what would be the settings of your fractional CO2?
They are the good, the
Low,
ones.
low level?
No,
No, low fluences or?
You see, you have to create micro channels. Your spacing has to be high. The coverage has to be 10 to 20%. Your energies have to be high, and the micro thermal zones of injury have to go deep into the dermis to eliminate the dermal pigment. So therefore, no low, because low is meant for superficial rejuvenation. Here we want to, something like what we do for scars. We have to do similar, because we have to go down into the dermis and create that channel right from the dermis to the surface.
So then your aftercare must be very strict. And
You have to, sometimes we use, you do generally use these epidermal growth factors, hyaluronic acid and sunscreen for about
do you
2
add
weeks.
exosomes?
No, I have not added exosomes, but yes, epidermal growth factor, hyaluronic acid and sunscreen. Hyaluronic acid containing moisturizer, sunscreen and epidermal growth factor.
And do you keep the spacing longer between sessions? Because
My
you've done
spacing is always longer. I now have moved to about 3 months, because I find that they keep on improving, and unnecessary doing it, maybe I was doing it at 1 month earlier. Now I do it at about 2.5 to 2 months.
remodeling continues.
Yeah. And not
And
only
the-
remodeling,
and
the
the expulsion of
clearance
the
of the pigment, because the
pigment, yeah.
pigment basically that you have, split around in the dermis is picked up by the macrophages slowly, and it happens over the next 2 to 3 months.
For
Thank
the
you.
fractional CO2, is there any specific type of melasma that you tend to do the fractional
No,
CO2?
I'm not talking about melasma.
The
This is
nevus,
about
yeah.
nevus of Ota.
The nevus of
Now,
Ota, sorry.
nevus of Ota, tattoos, horis,
Okay.
all these, dermal pigments I treat in this way. I do multiple passes with different spots, and I do a final pass of carbon dioxide laser, and I feel that the results are better. Melasma, no, never.
Okay, yeah. Thank you.
You just mentioned exosomes, right? And as per your practice, have you actually seen results coming with exosomes in terms of melasma and pigmentation? If yes, what was the method you used and the spacing between the treatments?
No, I don't use exosomes after such aggressive therapy because
Initially, I mean.
initially,
Yeah.
exosomes help with skin quality, light reflex. So
Not
they,
in melasma cases for melasma or pigmentation.
I think this is really what they do: improve skin quality
Yeah.
and improve the light reflex. I think that helps, but I don't know how much they actually work on melasma itself. And it doesn't guarantee that your treatment will be successful, and it doesn't guarantee that the melasma won't come back.
Yes.
If you're back
yes,
to
for
square one, it's an adjunct you add,
melasma does, yeah.
and patients feel better because if the skin quality is better, light reflex is better, they can cover it better with camouflage or makeup, then they're happy.
One more question I had for my colleagues who said they try to use tranexamic acid orally. How do you deal with patients with thromboembolic events, and how do you deal with them if and you're giving them systemic tranexamic acid and they have to go long term on the treatment?
So before, you mean like oral, right? Okay. So before I prescribe the oral tranexamic acid, I will talk to like all my patients that is like in the higher dosage one. It's like let's say like 5,000. Yeah, 5,000 milligram. They use it for like for the other purpose to have the blood clot, right? But I would tell that to my patients. I tell that to my patient. It's like, and normally for melasma we use 1,000, which is like a very low dose compared to the dose that we want a blood clot. And in 1,000, there is no report of the thromboembolic event. According to all the studies, there is no thromboembolic event. I told my patient that. And the dosage that I normally use is just 500. So it's very safe, but however, there is some contraindication, such as the oral contraceptive pill or any like if they are prone to have the cardiovascular disease or the DVT, I would tell them I'm not going with that. Yeah. And the duration, for me, I will tell my patient 3 months. But I read the studies, there's only one study. They say it's like you can prolong it until 6 months. But for myself, I like 3, the max is like 4 for me. How about you? How long do you prescribe? Okay.
But don't you think at 3 months it sometimes just starts working?
Yeah, that's right. I think it's not enough. 3 months, you probably you only start seeing. You start seeing the result about 2 or 3 months later, just slightly only. Then you just have to continue until 6 months then you see some very, very good result. But the problem is that then you ask yourself, how should I continue or should I stop? Because I don't think there's any study now at the moment that says prolonged treatment has got no side effect.
Only one they say it's like 6 months, but
Yeah.
it's the expert opinion.
Yeah, and the problem is that then you say, okay, I think we should stop, and we tell them to stop. And after stopping, within 3-4 months, the melasma all comes back again. And then the patient will come back, I want some more, give me some more. And before you know it, the patient will be taking it for 1 or 2 years already. Because they keep on coming and pester you for that. Because it's very effective, it's extremely effective compared to anything else.
Do you think it's worthwhile giving the tranexamic acid orally during the course of the procedures? Because it may aid in better clearance, and then give it a break. And would you use lasers for maintenance? Would you call the patient back every 3 months and do a laser for maintenance? Dr. Patrick, Dr. Go, is it worthwhile? And Dr.
Most
Anil?
of the time, if you put the patient on tranexamic acid orally, you don't need anything else. They all work wonderfully. So that's the reason why we use it as a second-line treatment nowadays, If topical treatment, all the things you've tried has failed, you just start them on tranexamic acid, provided they don't have the risk factor like thromboembolic disorders, some genetic clotting disorders and all that, or cardiovascular disorder. We just start, and then the patient will be very happy with you. And then the only problem is that when they get angry with you is when you stop them. And, it's like nowadays we have this same problem with oral isotretinoin, some people now have put them on very low dose, 10 milligrams a day or 10 milligrams a week. And the patient has been taking for 2-3 years, and then you say, stop, you get angry with you. You scold you and all that, and say, look at my face, I'm so good now. So tranexamic, we are facing the same problem. And my patient always say, I want some more, I want some more. So I don't know when to stop. And I think the challenge is that how safe is it? We have no idea. Somebody must go and do a longitudinal study to see if you take for 3 months, you have what have you got? 6 months, 1 year, 2 years, 10 years, or I don't know.
There is a way that my professor do it too. It's like the rescue dose. It's like after you stop, you for 2 weeks when you would get exposure in the sun, and I think we are trying to conduct a studies. It's like if it's the rescue dose will help with the relapse of melasma. Yeah, but I'm excited to do that too. Yeah.
About the lasers, I think there have been 3 phases. We started with absolute no lasers for melasma. Then we became very, very excited about this laser toning, and lots of studies coming in. And now Dr. Go talked about the hypopigmentation, the mottle thing. I think it has again gone. In my practice, it has gone to, very low. It is done only for patients who have had no response after about 3 to 6 months. So only those patients I provide lasers, and many patients come in, I want a laser for this. So I tell them laser is an absolute no, and in fact, they have been already told at many centers that yes, you need laser for this. So they come asking for laser, and I send them back not to take laser. That's one thing. The other thing is, as tranexamic acid is something for melasma like isotretinoin is for acne. So it's really wonderful. All the patients who get tranexamic acid, almost everybody responds. And I have been using tranexamic for 2 to 3 years also. I get down to a 250 milligram daily or maybe 250 milligram alternate day, and many of the patients are happy. So I think there are studies now for up to a year tranexamic acid has been. And about, thromboembolic phenomena, history of oral contraceptives or cardiac disease, I think that's an absolute no. That's an absolute contraindication. We should not give at all.
I agree. But Dr. Patrick, do you agree that you dissuade your patient from a laser given now that you have the ruby? He's the laser man, exactly.
Well, actually, first of all, I have to make sure the patient got no response to oral medication. Then we start laser. So this is the first one. Then the second one is if the patient agree, no, they want to have laser, especially for the first time, I would try to reach the maximal effect, and then the patient come back by themselves. For example, every other month or even longer. So whenever they would like to have lighter skin color, they come back. And also, the fractional laser, no matter which wavelength they are, actually they also bring thermal effect. So fractional laser also makes skin shiner and less wrinkle. So they are not coming back for pigmentation. So they're coming for the fractional laser to enhance everything altogether. So this is the reason why I think this is smart. I think this is better, in my humble opinion, that the patient coming back because of it's a multifactorial improvement and enhancement.
So that's the exact opposite. I think it depends on your patient's mindset. Exactly, which is why his patients come back. That's what I'm trying to say. It's a patient's mindset. It's which laser you have. It depends on the weather conditions you practice, the kind of patient profile you have. Melasma is not just as simple, like the pathogenesis is complex, but even the patients are complex. And there are a lot of complexities, which is why we're having such a long 1.5 discussion, even today on melasma, which continues to feed our practices as well as challenges us. So thank you so much.
Well, actually, if we want to disappoint our patient, they will leave. Exactly. So that's why.
Exactly, that's the truth. I'm glad you said it. That's what I was driving to. So I'm glad you said it coming from an expert like you. But thank you, Dr. Go. Thank you, Dr. Patrick, Dr. Anil, and Dr. Yada. And unfortunately, the first speaker couldn't get her slides in. But and thank you, Dr. Lila. Yeah.
Okay. So thank you all speaker and the delegates for joining us very interesting and updated session today. Thank you. Please enjoy your stay in Bangkok.